Alrighty. So this is short. This is a tumor. Okay. This should really be under endocrine, not under cancer. But here we are. Pheochromocytoma is a tumor. It's quite rare. Usually benign. However, the problem is it's growing in the adrenal medulla. So we discussed Cushing's and Addison's disease. So the problems there were with the adrenal cortex, where the salt and sugar hormones are produced. Now, this is the medulla part of the adrenal glands, same adrenal glands. However, because the medulla produces the norepinephrine and epinephrine, so what's the problem when you have a tumor growing in that part of the adrenal glands? What will the tumor produce?
Obstruction.
Well, in the case of Cushing's disease, there was a tumor also, correct? The tumor either in the pituitary gland or in the adrenal cortex. What did the tumor do to the salt and sugar hormones? Did it cause it to increase or decrease?
Increase.
Increase. So same thing here. So there's a tumor growing on the adrenal medulla. So what will the result be? The tumor will likely produce what?
An increase in the hormone, Professor?
Yeah. All right. So it will cause an increase in epinephrine and norepinephrine. Now, what will a patient like that look like? They have high levels of epinephrine and norepinephrine. So imagine if you have that. No comments? So what will happen to you if you have high levels of epinephrine and norepinephrine? What is the effect of epinephrine?
It will relax the muscles, Professor? Will be like numb?
Epinephrine.
Increase heart rate.
Increase heart rate.
Increase heart rate.
And what else? Keep it coming.
Stress hormones.
Increase blood pressure.
Increase blood pressure. Yeah, the stress hormones aren't involved here because that's in the cortex. So the glucocorticoids, mineralocorticoids, which are cortisol and aldosterone, are coming from the adrenal cortex. They're not in the medulla. So only the catecholamine production is the problem here. So the patient has really high levels of epinephrine, really high levels of norepinephrine. So this is the most nervous looking hypertensive patient you can imagine. So they have high blood pressure, and usually the cause of death is either they'll have a hemorrhagic stroke or malignant hypertension, and they'll just die, okay, because of the sky high blood pressure. Before they die, though, the high blood pressure can destroy the kidneys, causing acute kidney injury. It can destroy other organs, okay, just because of the high pressures, okay, so they will damage multiple organs, and it's not a peaceful death, okay, it's a really a painful, gruesome death. The tumor is also quite big. When the patient lays down flat, if the patient is in a supine position, the tumors are quite huge. It becomes palpable. One thing you never do is press or palpate the tumor, because if you do, it will cause a sudden release of epinephrine and norepinephrine. The patient will literally stroke right in front of you as you're doing that. All right. Since it's a tumor, so what's the likely treatment?
Surgery.
All right. So the patient will undergo surgery. Since this will result in adrenalectomy, is the preparation pre and post-op different from the adrenalectomy we did for the Cushing's disease patient?
Same, Professor.
Exactly
The same.
It's the same organ. So will the patient develop adrenal insufficiency after the surgery?
Yes.
Yes.
Yes,
Yes.
exactly the same. All right. Depends really if the tumor, if the pheochromocytoma is growing on both adrenal glands, in which case the patient loses both glands, or if it's only on one, then they won't have insufficiency. Okay, adrenal insufficiency. Okay, until then though, we'll have to just manage the patient's blood pressure. Let's continue with the manifestations. So I already mentioned sky high blood pressure, sky high heart rate. So palpitations, high blood pressure, and the rest of these are really signs and symptoms of severe hypertension, namely headache, diaphoresis. These are the common nuchal pain, pain in the back of the neck. Those are the usual manifestations of high blood pressure, extremely high blood pressure. But then the rest would be related to the high epinephrine and norepinephrine levels. But the hypertension really is the most serious manifestation. Here are other manifestations: tremor, headache, flushing, and anxiety. Anxiety results from the palpitations, the tachycardia. And as I mentioned, there is a palpable tumor. Sometimes it can be big enough to cause problems in the abdomen as well. It can cause bowel blockage, even constipation. Here are more manifestations of really high blood pressure. Okay, so those are accompanying hypertension, severe hypertension manifestations. Look at the blood pressure; it can reach 250 to 150. Okay, so you can imagine the life-threatening complications from that. And these are the possible results. They could die from a dysrhythmia, an aneurysm, a stroke, as already mentioned, and AKI. Okay. So these are the signs. So there are 5 H's in pheochromocytoma: hypertension, headache, hyperhidrosis or excessive sweating, hypermetabolism, and hyperglycemia. Hyperglycemia is the effect of epinephrine also, since it's an emergency hormone, so it will also trigger breakdown of glucose. It's a fight or flight hormone. Okay, as mentioned, there's a palpable tumor here, so don't touch or you can touch it, but don't palpate the tumor. Here are some foods that should be avoided during the testing. Okay, they're mentioned here. Okay, so not to alter the test results. Let's go straight to the management. As I said, the patient will require surgery. However, not all patients will be candidates for surgery. So if they're not ready for surgery yet, then we will do management of the symptoms. So we will give them boatloads of antihypertensive medications, from beta blockers to calcium channel blockers, ACE inhibitors, ARBs, diuretics as well. So they're all mentioned here. The target for the blood pressure is less than 130/80. And once we're there, then we can safely schedule them for surgery. But until then, like I said, we'll load them up with tons of antihypertensives. And this is the procedure. Again, I won't repeat the pre and post-op care for adrenalectomy, since that was covered already under Cushing's disease management, surgical management. Okay, let's talk about the hypertensive crisis. So how do you handle someone with really high blood pressure? What are the steps you take? So this is not any different from autonomic dysreflexia. You remember preeclampsia or malignant hypertension in NUR 141? What were the steps to manage someone with really high blood pressure? What is the first action?
lower blood pressure.
How?
Drug therapy.
Actually, well, drug therapy will take time, right? Because you have to go get the drug, draw it up, administer it, granting the patient has an IV access. But what's because there were steps in preeclampsia, there was a chart because it's an emergency. So any life-threatening emergency, if you notice on every textbook, they have a chart, right? Either a chart or a table. So what was step number 1 in preeclampsia? I know we haven't talked about autonomic dysreflexia yet, but here's another hypertension problem. So preeclampsia, autonomic dysreflexia, hypertensive crisis are all sky-high blood pressure problems. So what was the first step that the nurse will do? Followed by medications. What position would be best? What position will you place the patient? That's the first action, positioning. What's the first action? How do you position the patient?
Phone.
What was that?
And phone.
Left side,
No.
In the supine position.
supine,
No.
No?
prone,
No. Okay, place the patient in a sitting position, all right? So if they're laying down, sit them up. If they're standing, sit them down. All right, that's the first thing you choose. So place the patient in a sitting position and then go prepare your medication. Until then, you also monitor the patient for neurologic their neurologic status. Why? Why do we monitor neuro assessment? You know, mental status and all that. Why are we checking that? What's bound to happen when they have a blood pressure of 250 over 150?
Option the brain.
Okay, they could have a hemorrhagic stroke. So monitor neuro status. And this is not only for this patient here with pheochromocytoma, it's anyone with high blood pressure. So a preeclampsia patient, this pheochromocytoma patient, the autonomic dysreflexia patient, okay? Anyone with high blood pressure. Is that understood? Because management is the same. Okay? So we treat them exactly the same way. Sit them up or sit them down, prepare antihypertensive medications IV, and monitor neurologic status. All right. These here we already discussed in the Cushing's chapter. With the after surgery, of course, remember what will the patient develop if, let's say, they lost both adrenal glands? What does the patient develop afterwards? Okay, or adrenal insufficiency, correct? So therefore, now the blood pressure is low, the blood sugar is low, the potassium is high. All right, so prepare for that. I mean, we discussed that extensively under Cushing's. That's about it for about pheochromocytoma. Any questions? Alrighty, let's proceed with, I don't know if Conn syndrome is in this book, but let's see. If not, I'll just describe it, and in case you get it on the NCLEX. Okay, it is here. Okay, let's see.